Welcome to our latest episode on leadership and culture in healthcare, podcast on insights into healthcare and leadership. And we're in series 5, and we're talking about groups. We're talking about how organizations operate together and the leadership asking that. And we have someone who's been living and breathing this for quite some time, Glen Burley. Glen, welcome to the podcast. Why don't you start by introducing you? What do you do? What's your group? And just give us a bit of taste of that world.
Well, hi, Matthew. Thank you. And it's good to see you again. And thank you for inviting me into this podcast. So I'm Glen Burley, Chief Executive of the foundation, what we call the Foundation Group of Trusts, which is a group of 4 trusts in the Midlands, the West Midlands. So it started out of South Warwickshire University Foundation Trust, then Wye Valley NHS Trust, which is in Hereford, and then George Elliot Hospital Trust, which is in North Warwickshire, and then last year Worcestershire Acute joined us. So the way we're configured is that they're broadly similar organisations, actually, and that's what we've gone for with this model in terms of synergies of the organisations. So mainly acute integrated with community services. It's not the case in Worcester, but we're looking at how we could do that. But the geography is interesting because it cuts across a really big geographical patch, but it was never about organisations being next to each other, seeing a group. It was more about organisations with similar challenges in scale working together.
So that's a big spread, isn't it? So that's across 3 different counties or 2 different counties?
So you've got whole of Warwickshire pretty much, Worcestershire and Herefordshire. So and you've probably got about 100 miles distance between the furthest distance between the acute side. So yeah, it's pretty big geography.
And so interestingly, you said that Worcestershire joined the group. So to help people understand, I mean, how did South Warwickshire and Wye Valley, then George Elliot come together? And then that thing about Worcestershire joining, they were joining something established at that point. So I'm sure that was a different dynamic than the original kind of 1, 2, 3 organisations.
Yeah, so if I do the kind of brief version of the history of this one, for me, these things work if they are things that the organisations want to do. So this started off with South Warwickshire Trust helping Wye Valley Trust, who were in special measures. So it was the buddying arrangements of a few years ago. And through that buddying arrangement, Wye Valley left special measures, but we also realised that the 2 organisations have got a lot in common. And despite the fact that South Warwickshire was a good rated organisation at that point, it moved to outstanding actually after that. It was good rated and one was inadequate rated. We realised there was some really good practice in both organisations. So we started to see the opportunity to share between the teams because they've got similar challenges and similar scale. So at the end of moving out special measures, we said, actually, this is a relationship that's got some legs that we could keep into the future. So we moved then to create a group model that had a shared chair and chief executive. And obviously I was the chief executive in that model, but sovereign organisations. But I was particularly keen to ensure that that was a choice that the Wye Valley board made, that they wanted to move into, and equally South Warwickshire, that they wanted to be part of this. So having set that up, about a year later, George Elliot Trust, who had decided that they were not financially sustainable in the long run because of their scale, they came knocking the door to say, we actually quite like what you've set up here and we wondered whether we could join. There's also synergy there because community services in Warwickshire were run by South Warwickshire, so that there's an opportunity to integrate through that. So the George Elliot board considered the position and asked if they could join the group. And then that question was put to the Swift and the Wye Valley boards and they said, yeah, that'd be great. And then the same thing with Worcestershire Acute back last year, where we basically were presented with them saying we'd like to join the group. We can see some good things moving on. They'd actually been an associate member of the group for a little while. David Nicholson, their ex-chair, liked the idea of the group and wanted to join in with some of the improvement work we were doing. So they were able to see what we were doing. And then they said, we'd like to formally join. So put simply, the joining of our group is about taking on a common chair and chief exec. And so we have the same chair and chief exec across the group, creating a committee in common, which is what's called the Group Strategy Committee, which is a subcommittee of each of the boards of the trust. And then not lots of governance on top of that, actually. So we've got, the way I've tried to set it up is the same governance structure, so the same committee structure in each organisation, executives with the same portfolios in each organisation. So you've got that kind of phone a friend opportunity, but not creating a layer of group leadership. We've got one or two advisory roles, specialist advisory roles. There's a medical advisory role, there's a financial advisory role, but they are advisory. So they're like consultants, management consultants. They advise the execs in each organisation. So we've not taken any power out of the boardrooms of each of those individual trusts, but we've added the horsepower of the kind of bigger organisation and the scale. And lots of other things have come on the back of that, to be honest, Matthew. It's things that I didn't necessarily think we would be doing together. We've started to realise there's opportunities to do together. And that's really stemmed from creating that trust and that approach that says that, Swift is outstanding rated now. The others have, one's just about hopefully to move to a good rating. The others are requires improvement, but they're all good. They're all elements of them that are really exceptional and outstanding. And so we're all peers. So all four trusts have the same status in the group. And I'm very quick to kind of make the connections between them to make sure that if there's a challenge faced in one organisation, you can see where there's some good practice elsewhere. And we facilitated that through a range of things, including integrated performance dashboard that's common in each of the trusts. We now meet on a quarterly basis of all four trust boards together, where we do look at performance and where we do compare how each organisation is doing against certain challenges. And now we've also got a common strategy for all four trusts as well.
Interesting alignment that happens, I assume, through trust and developing those relationships, because you started with a few things together, then that kind of added and added and added. And I guess what was interesting in what you were describing was that George Elliot and Worcestershire Trusts asked to join. So I'm assuming their boards had gone through some process themselves, probably for sustainability purposes or future purposes, and actually did that kind of objective analysis of what's best for our organisation and our residents and our staff. Is that how those two happened to come and join the group?
Yeah, they did, and obviously separate from any involvement from us, they considered their options as organisations, and then approached us to see whether they could join the group. And at that point, for certainly, so the Wye Valley situation was slightly different because we had that buddying relationship. But for George Elliot and Worcestershire Acute, Chairman and I went along and spoke to the boards and said, this is how the group works. These are the things that I think we need to keep consistent if you wanted to join us, but these are the opportunities that stem from that. So I think it has to be, and I see some examples of groups elsewhere that maybe are a bit forced, and then it's a really tricky thing to do. So it's so important that it wasn't forced. It's so important that there still is that sovereignty of the individual organisations, that they are focused. Actually, more importantly, they're focused on the places in which they operate rather than the group. The group is a facilitator of doing some of the good practice in those areas, but it's their most important provider collaborative is not the group. Their important provider collaborative for each trust is the system, the place in which they work, the organisations they work with, and in all cases actually leading to that lead provider of place role.
And so you've got joint chair, joint chief executive, you've a kind of joint strategy, you've said you've got similar exec role in similar ways of operating, harmonization of the kind of methodology across each trust, and a platform that gives the same kind of data. Explain to our listeners about this kind of committee in common. That might be a bit of an alien concept. What responsibility does that take across, and does it replicate or does it do something different to the trust boards? Because I assume the boards of each organisation still meet.
Yeah, so the boards of each organisation still meet and very much in control of their destiny and their strategy. The committee in common is deliberately a minority of each board. So in order to facilitate me working as chief executive for trust, there's a managing director in each organisation. So the managing directors are in the committee in common. We've got their trust strategy, chief strategy officers, and we've got the chief medical officers and a non-executive. So the idea is that that group strategy committee has membership from all of those individuals in each of the trust, but then makes recommendations to each trust. Those recommendations, then when they go into the trust board, it's the minority of people that were in that subcommittee. So the majority decision is made by that board. When I originally set this up, I wondered whether we might give delegated authority from the individual boards to the committee in common. And some groups have done that. But I've never needed to. So the principle that still operates today is that recommendations from the committee in common go through to the individual boards, and the individual boards could say no if they wanted to. But hopefully they've gone through enough of a test through the committee in common, and they've had the input of their representatives on that, and we've got it to a position where those things are carried. So I've not needed to give it any delegated authority.
And I think you were talking about, it sounded like to me, some opportunistic approaches that kind of presumably have emerged as you've gone along. Has that involved common infrastructure for things across 4 organisations, so you only do it once?
Yeah, so a lot of sharing. So principally, one of the things that we talk about is sharing best practice at pace. That's one of our mantras across the group. So a lot of this is about sharing what we've done and not necessarily saying you have to do this, but have a look at what they're doing at George Eliot and see if you've got a version of that you want to bring into Worcester or Wye Valley or Swift. So there's a bit of that, but the kind of back office type opportunities are there. But then it's not always about saying group is the solution to everything. So South Warwickshire and George Eliot are neighbours in the same integrated care system. And so we have moved there. We've got a single IT function as run through an arm's length company. We've used Swift's Foundation Trust status to create an arm's length company that runs their IT. That's working really well. Over in Wye Valley, their IT is a collaboration with the local authority. Why would I want to change that? Because that's a really good local collaboration. So it's really been based on business cases stacking up rather than a kind of concept that we're going to do everything at group level. Swift and George Eliot are putting in a common IT system. Wye Valley and Worcestershire Acute have now moved to a lead provider model to solve the problem with dermatology in Worcestershire. So it's really horses for courses. But one of the questions is, can we solve this as a group? But it doesn't always have to be the group solution.
And that's why it's an adaptable, permeable model, isn't it? Because I suppose at the heart of that might be is your accountable officer for all 4 organisations. The buck stops with you in terms of your accountability to Parliament, to external groups. And with that kind of permeations on it could happen this way or could happen that way, how do you operate as the group chief executive to say, I'm assured that what we're doing is good everywhere or fabulous everywhere?
Yeah, that's a tricky one.
It wasn't going to be an easy question, Glenn, because you've been at this a while, so we need your expertise.
Yeah, to probably do a bit of context on that is in chief exec 18 years at South Warwickshire. And so I suppose some of this is you build a bit of confidence. I suppose what I've also learned along the way is that if you try and force solutions into organisations, into clinicians particularly, that you can sometimes face it's not invented here type response and it can go wrong. So I've always seen the benefit of convincing people, but also encouraging people to do their version of good practice. So that's why it's not the same approach across the group, because if I just come in and said, you've got to do it this way, this is the group way, you will get immediate resistance to that and it would fail. It does create a degree of risk for the accountable officer, the accounting officer of the individual organisations, that I've got some slightly different nuanced situations going on across the group. But to be honest, they've all got different they're all in different contexts. They've all got different HR issues and recruitment issues and service issues. So you do need to be able to flex the model a little bit. I know certain things that work, and I generally will promote those, but I'll not go in with you've got to do this because I know it works. It's more of a convincing type approach to say, actually, this is working over here. Take a look. And actually, through taking that approach, what I've also found is that often when you encourage someone to go and take a look at something, they then come back with an even better version of what they've seen. And so you have this continuous improvement loop going on. And so it's even better then to go back in a year or so's time and say to the trust that they learned from that they've actually done a better version of this, and go and have a look back at what they've done. So we try and keep that continuous improvement. And I suppose that approach to improvement is a fundamental part of this also. And that's partly a kind of sharing best practice, but it's also that devolution of responsibility and accountability and empowering people to make change happen in their place of work, in their team, in their system. And so you're always going to, therefore, if you believe in a kind of ground up approach to improvement, you're always going to have different practice going on. Because the worst thing in the world would be to say there's one way to do this and you just do it that way. And you would never improve it. So I'm comfortable with the slight level of risk that creates, because it creates continuous improvement.
And you've just talked about, which I'm sure is probably a core element of the answer to my question, is actually it's not about you. It's about, no offense, but it's about devolved power, and it's about having great leaders out and doing that. And I know that's always been, knowing you for quite many years, it's always been something you've done in South Warwickshire, and you've done with all that. Is that an approach that you've taken to build leadership and build approaches that actually becomes the devolved leadership ask, and therefore your accountability is frankly a lot easier to discharge at that point?
Yeah, completely. I didn't say this at the start. I'm an accountant by background. So, what do I know about some of those clinical services? But what I do know is that, creating the right environment that gives people the ability to make change happen. And that means a degree of risk taking. That also means it's important how you handle that when things don't quite go to plan. And so you see them as learning opportunities rather than opportunities to criticize and challenge people. So yeah, I've probably because of being an accountant and working firstly as an ops director, actually. So I was a CFO, then an ops director. I've always kind of lent into the clinicians and wanted to listen to their views. And I think the best NHS organisations will get the balance right between decision making and managerial and leadership actions, but also that kind of clinical engagement, empowerment, allowing people to really realise the improvements they want to make in their service, and also recognising that however good we are, we can always be a little bit better.
So before we just maybe drill into your role and your leadership style amongst all of that, which you touched on a bit, but I do want to just kind of talk about the differences. In your model, the Burley model, we'll call it. I know it's not just the Burley model, but the foundation group. You've got 4 organisations. Just looking ahead, is that scalable any further? Does that have the ability to reduce and expand, or just stay as you are? What's the thinking of the groups?
Yeah, good question. So, there's a little bit of me in all of this, where I think I would be a little bit concerned if it got so big that I didn't feel I was close enough to what's going on, and that's quite challenging at the moment, because the geography and the organisation. So a lot of my leadership styles had to change quite a lot over the years, from a really hands-on, loving getting involved in solving problems, into a kind of more of a coaching style, actually. So the managing directors are really important in that, and it's important from that they understand my values and they share them to an extent, but also that they feel empowered to make decisions without having to come back to me. And so I've had to move more into the stands than being on the pitch, for want of a kind of sporting analogy of this. But I still base myself in a hospital, and I still love to get involved in it. And whilst I try not to step on the toes of the managing directors, I do love it when they ask for a little bit of advice or support on something, because it's just getting close to the clinical teams in the NHS is what drives us all, I think, actually, because they're all so great.
So does the scale then is the parameters of the scale how far you're personally able to think I can still discharge my responsibilities without it being too diluted?
Yeah. So there's that balance between the enjoyment of the role and being close to what's happening, but then also the accountabilities of the accountable officer and risk. And I wouldn't want to be in a situation where I was completely superfluous, just kind of making sure everyone follows the protocol, because I think I don't think you can preside over an organisation in that way. And I'm still quite sensitive about the fact that I don't get to see as many of the frontline clinical staff as I did when I was a chief exec of one organisation. So I have to make sure the managing directors, the other execs, do that, because I think leadership is a contact sport, and that's really important. And so I have to play a slightly different role in it. And so I wouldn't want to be so diluted that I don't feel part of it, or that I'm not kind of adding value to them. Otherwise, they might as well be chief execs in their own right, to be honest. And two of them already have been capable of moving on and doing that, which has been great.
And so digging for me a bit, Glenn, in that you've started to talk about the style. So you said your style has moved to be less hands-on, less on the pitch, more on the stand, more coaching. What else has changed being a group executive than just? I'd say just, because South Warwickshire is still a big undertaking, but South Warwickshire's chief executive.
I think one of the other important parts of probably a chief exec role, but also probably more so at group level, is providing a bit of cover for the organisations. So we go through some tricky times in the NHS, don't we? And I suppose part of some of the trusts that have joined the group as we've gone along have gone through some tricky periods. Worcestershire Acute, I'll talk about. A lot of external scrutiny, a lot of interventions over time. So part of what I've tried to do is create a bit of an umbrella to allow them to get on and do some of the things that I think are the right things. But that means for me kind of facing the NHS England a little bit more and the system a little bit more. So for me, it's kind of moved that focus into maybe more kind of system national influencing work, as opposed to what's going on within the individual organizations, but again, getting the balance right on that, so that I'm always thinking about what happens next, actually. And the kind of what happens next is, does someone else come in and do what I'm doing, or do those organizations, have they moved to another level where they can maybe have a looser collaboration and have 4 chief executives? So I don't think there's ever a kind of finished point in any model. And I've learned that over the years. When I first joined the NHS as a trainee accountant, I wanted to be a district treasurer. They don't exist anymore, and so I think you shouldn't get wedded to, this is where we're going, this is what the kind of ultimate career path is for people. I think you have to be responsive and reactive to it. I'm not sure whether I've answered your question. I went off in another tangent.
Yeah, but I think, and we can talk about then kind of what next and succession planning, because I think that's really important in that. It's not that no one wants to get rid of you, Glenn. The venerable Glen Burley, we can't do that. But what I suppose I'm interested in, are there skills that you've had to think, I'm going to have to sharpen up on some of these skills because I'm going to be using this more, rather than, as you say, the out and about, touching, feeling, smelling what's going on in the wards, in the community teams, etc. Are you using other things instead?
Yeah, but I mean, I've done 41 years in the NHS now, and I'm not the finished article. And I suppose part of going through a finance role and then a coup role and then a chief exec role and then a different trust role is I've always tried to keep challenging myself. And I'm not being wedded to thinking that, I know all the answers or the the pike and slippers time, I'm a chief exec and, I've made it into the role I wanted to be into. So I'm always looking for how I can do things differently and to learn from, and people like you, to be perfectly frank, who've done some great things in other parts and, have got other experiences. So I think you have to be ready to react to an ever-changing picture, actually. Who'd have thought we would be moving into kind of lead provider roles? When I first started out, we went through that era where primary care was in a completely different organisation to what's going on in the NHS. So that's an area that I think is really fascinating for the next phase of this, the extent to which lead providers like mine can start to play more of a role in joining up the other bits of the system, including primary care, and to do that well by empowering primary care rather than leading primary care in a different way.
Yeah. And maybe we'll touch on that in a moment. That's probably a whole new podcast theme, isn't it? About how one does that in a different way. But you touched on thinking ahead. And I think an interesting challenge is to all the group roles is, how on earth do we replace you? Because whatever you do, there is a Glen Burley stamp on the foundation group, isn't there, with your chair? And lots of it will become because of your passion, your skills, your enthusiasm to join things up and do things in a better way. How are you thinking about succession planning and future people to do your role? Because I'm intrigued, aren't you? You did 18 years at South Warwickshire before you did this role. That's a long training. That's a long training, isn't it?
Yeah, so it's 18 years in total.
Including, I can do right.
And the group's been around for the last kind of 6.
Yeah, there's still a good watch as another chief executive. So what's in your mind about how we get that right for the future? Because we don't want it failing because you're not there. We want it to flourish and go into this next iteration, don't we?
Yeah, so there may be another better version of me coming along or too long. Equally, I think one of the reasons why I've structured it in the way that I've structured this group is that actually, you could take an organisation out of the group quite easily. Yeah, I've not created this thing that is dependent on me. So, let's take Wye Valley. They've been in this for a while now. They've moved to a much better place. Not through me, but through a bit of cover from me and doing the things that they wanted to do. You could put a chief exec in there. They could just be part of a provider collaborative moving forward. So I think there's multiple options on this model because it's not created this layer that binds them forever together. But what they do get is, the benefit of the scale, the benefit of sharing with the group, the benefit of some of those advisory roles. We spend virtually nothing on management consultancy as a group because I put people into this arm's length company that have got great skills, people that, have worked in the NHS and maybe don't want to work full time in the NHS anymore. So we just got, at the moment, it's for each board to say, if they could say tomorrow, any one of the boards could say tomorrow, we don't think we're getting value out of this, we could walk away, and they could. Appoint their own chief exec, appoint their own chair, and they're away. So it's not like I've created something that is dependent on me. So I think when me comes to an end at some point, as I say, it's either carry on with another version of me, take it to a different level, do things differently, or you could go into 4 trusts, you could bring a couple of the trusts together in the ICSs or whatever you wanted to do. So I've tried to keep that flexibility because the last thing, and I think an important thing for any leader is to think about what happens or what would happen if you weren't there. And I think the best leaders get into a feeling that actually if they weren't there, it'd still be fine, actually, because there's a legacy of a strategy and a feeling that can move it forward.
And I suppose I absolutely understand that. And it's interesting there are choices to be made, and no doubt every board would make those choices. And even indeed when a chair steps down, it will be like, do we want to continue with one chair, yay or nay? Which I think is a healthy challenge, isn't it, to have that right? Because it almost gives the mandate for the next period. I think the interesting thing in leadership terms is how are we training our next set of group chief execs as much as how do we train our next set of managing directors or individual organization chief execs? Because I think I'm getting more convinced that these roles, I think, need experience, but they also need an element of resilience and a different set of mature skills that you might not just get as soon as you move into a chief exec realm.
Yeah. And I know there's a bit of a worry that the more groups will create, the fewer chief exec opportunities there are. As I said earlier, I think the managing director roles are great feeder roles for those, and that's already been proven with a couple of great individuals who've been part of our group. Actually, elsewhere, another the managing director where Nathan's said, I'm really happy doing what I'm doing. I like the cover. I like someone else having the stuff that goes with being a chief executive. So I think we just have to think about everyone's opportunity to continue to grow and develop. So it's not just about chief executives. It's about all the executive roles. It's about sub-executive roles. It's about chairs as well. So, it's great. Russell Hardy, our chair, is fantastic. But we're also having to think about, what happens when he has to stand down because the nature of the chair appointments. We've got vice chairs. So each of the trusts has got a vice chair that does a little bit like the managing director, and they take on more responsibility than your average vice chair in a normal trust. So I think it's about creating a series of options and individuals who've got capabilities to step up to it, or options to reconfigure if you needed to. And as I say, there could be a policy tomorrow that comes out of the government, as part of the long-term plan, that says we're going to move in a slightly different direction. I think you have to be ready to respond to that also.
And then, Glenn, as we kind of pull the threads of this conversation, we could go on for ages, but we won't because we've all got other things to do. But when you look ahead, and I think you started to talk about, well, there may be roles for, a provider collaborative, a group to therefore play a different role going forward. And I think I know in elements of your organization, you've got, some really great social care dynamics and interactions with Warwickshire County Council and others. What's in your mind in that? Because I suppose I'm hitting there thinking, you've used the word autonomy and you've used the word sovereign organizations a few times. I have to say, I don't like the word sovereign when it's connected to an organization, because it kind of almost smacks of, I'll do what I want to do. But I got a feeling you're not talking about that. You're talking about an organization that is far more permeable and actually takes responsibility for more than its own kind of set of requirements. It becomes a public benefit to all. Am I right in thinking that?
Yeah, you're right to pick me up on that term. And I mean, it's just really, from a governance perspective, it's just making it clear that we haven't created this kind of group thing.
Yeah.
But actually, the role that I describe as the opportunity moving forward is, it's probably more of a, we talk about lead provider. It's probably more of a convener, actually. It's probably more of an integrator role. And I think it's just recognizing the fact that if you take a place like South Warwickshire, you do probably need an organisation willing to take the population health risk on. And so you need a degree of scale to do that. And South Warwickshire is in Swift, South Warwickshire Foundation Trust, in a great position to do that because it's got acute and community services. But then how you work with the other partners in that is so important. And I think you have to earn that. And again, it's the trust thing. You have to earn that trust and to work with those partners in a way that is actually delivering for the communities that we serve. And so we've worked through, I think I call them signature moves, but a set of behaviours that I think we need to demonstrate in order to be the organisation that is just seen by everyone as the natural organisation to take that on and not be threatening to people. And that will involve engaging primary care in leadership, actually putting primary care into leadership roles, because actually you don't run this at place, you run this at neighbourhood level, don't you? And that's where you need that primary care leadership. but then also working with local authority colleagues so that we, the commissioning responsibilities we will take on as lead provider in South Warwickshire, we're leaning into local authority to do that because we haven't got the skills to do that. They've got the skills to do that. We've got the leverage around some of the care services that they already commission. So it's just really trying to get together the right people to do the right things, to recognise there's really specialist areas like mental health services where you want to work with a really strong mental health provider, but you're willing to be the glue, you're willing to be the take the financial risk on all of that, but you recognise that you are not the best organisation to do it all. So lead provider is not sole provider. And so that mindset is important. And I think there's a fascinating leadership change there. For a lot of our people in the NHS, we are used to that command and control leadership structure as opposed to influencing behaviour, working with people in different sectors, in different organisations. And so I'm starting to think about how at operational level, actually, general managers, for example, start to take more pathway responsibility rather than just the teams and the services that they directly manage.
Interesting stuff. Ben, you've described the foundation group, 4 organisations operating in, I think, both strong and loose at the same time, but not loose in a bad way, but loose as in not straitjacketed kind of governance and development. You've described to us all about this was a choice, which we think is really crucial, isn't it? When we talk about culture, of how your managing directors are empowered to do their work. Your role is to convene and to cajole. I'm sure there's lots of other adjectives we could use, but actually it's about helping people to be the very best. You fascinatingly talked about your kind of ability and need to provide air cover for people, just to kind of almost back everybody off and allow them to do their jobs. And then at the end there, talking about where those things might go forward and what someone like the foundation group or individual parts of your foundation group will help deliver to be, a sum of all, the parts. The sum is better than all the parts, and actually get the best out of them. I mean, one final thought, Glenn, from you. What's exciting you? I know you get excited about loads of things, so I'm going to keep you to one thing. But when you look at 10-year plan coming up, you've got your 4 organizations working together, you've got relationships, things are in, probably in, when we compare it with other parts of NHS, actually working really well. What's exciting you and what are you looking forward to in the next stretch?
Okay. I mean, that was a really good summary. I actually might use that to describe what's going on. I suppose one of the reasons why, I'll try not to give a long answer, one of the reasons why I've kind of kept the South Warwickshire thing and then added other things to it is because that's where I started, and that's gone to a slightly more mature level of other parts of the group. Actually, Wye Valley's there on some of these things as well. So I've always liked the idea that there actually isn't any way to do some of this stuff, that you're breaking new ground on things like lead provider and integration. And so I'm really excited about the next phase of all of this and being in the position that we're in, where hopefully we can start to pilot some of the things I just described a minute ago. There aren't any rules written down somewhere where someone's going to say you can't do this because the rules say you can't, because I sense quite a strong level of permissiveness around some of this stuff. And I think that's really great to see. So I look forward to doing some things that I can't even think of today, because we hopefully will be in a position where there's a little bit of trust and confidence that we can try some new things. And because we will hopefully also then be able to evaluate those and drop the things that were rubbish and move some things forward that work really well. So I think the integration agenda, the social care integration agenda, the primary care integration agenda is something really quite exciting. And I know it's really, really tough financially, and that's a worry for all of us. But sometimes that in itself creates a momentum to try and do things very differently, which I think we can do.
Glenn, We're going to have to pull it to a close there. It's been wonderful talking to you, hearing your experience in talking about Next. Clearly, Secretary of State should be listening and taking notes on what can be trialled in the foundation group and local areas. Thank you for sharing your insights and joining Leadership and Culture and Healthcare podcast to talk about your experience in your leadership and the culture that you developed across the foundation group. It's been a privilege.
Thank you very much, Matthew. It's a great pleasure to talk to you.